Good evening. I am Dr. Ashish Bakshi, and today I have been given responsibility of presenting three trials. The extent breast cancer patients are at risk of developing late recurrences, and even patients who are T1 and T2 and zero disease are also at substantial risk of developing late recurrences. Several studies have looked at extending the duration of hormone therapy in order to minimize this risk of late recurrences. And many of these trials have already been published, and guidelines have also incorporated these trials. Now, we are today we will be discussing three trials. The first trial is the GM4 Lead Trial, which has been published in Lancet Oncology by Lucia Del Mastro, and this deals with the extended therapy with letrozole and adjuvant treatment in postmenopausal women. So basically, this was a phase 3 trial, and where postmenopausal women at study and they were postmenopausal stage 1 to 3, and they had received adjuvant tamoxifen therapy at least for 2 to 3 years. The primary endpoint was a invasive disease-free survival, and the patients were enrolled up from 2005 to 2010. Now, these patients had received 2 to 3 years of tamoxifen. After that, they were randomized to 2 to 3 years of letrozole or 5 years of extended letrozole. So, which means that the 2 to 3 year group received letrozole up to total hormone therapy duration was 5 years, whereas the extended group received hormone therapy up to the period of 7 to 8 years. And the median follow-up of this study is almost 10 years now. What this trial showed that the DFS events were 25% in the control group, whereas the extended group, the DFS events were lower, that is 20%. So the 12-year disease-free survival was 62% in the control arm, whereas 67% in the extended arm. So there was a significant benefit in disease-free survival by extending the hormone therapy. As expected, the grade 3-4 events were slightly more in the extended treatment arm. However, they were slightly only marginally higher, and no toxic deaths were reported. Now, the conclusions of the author from this study is that in postmenopausal women who have received 2 to 3 years of tamoxifen, extending treatment with 5 years of letrozole resulted in significant improvement in disease-free survival as compared to 2 to 3 years of letrozole. There was no overall survival benefit in this study as of now, which is statistically significant. Now, the second trial that I'm going to discuss is the ABCSG 16 or SALSA trial. This has also been published in NEJM by Michael Gant. Now, the ABCSG trial, it also looked at postmenopausal women who had stage 1 to 3 disease, and they had already received 5 years of adjuvant endocrine therapy, which included either tamoxifen or AI or both, and they were randomized to either 2 years of extended ET or 5 years of extended ET, which means the patients had received either 2 years of anastrozole or 5 years of anastrozole, and almost 1700 patients were there in each arm. Now, what this study showed was, again, in this study also, the primary endpoint was disease-free survival, whereas overall survival, contralateral breast cancer, and bone fracture were secondary endpoint. Again, the ABCSG trial also showed that in this trial, between 2 years and 5 years, there was no significant difference. So, extending the duration of hormone therapy up to 10 years is of no additional benefit as compared to extending it up to 7 years. They could not identify any subgroups where actually any particular subgroup benefited with this. And again, there has been no overall survival benefit in this trial. However, what the authors noted was that the risk of clinical bone fracture was significantly higher in the group that received hormone therapy, extended hormone therapy up to the duration of 10 years. So, which means 5 years of extended anastrozole. So, the author's conclusion are that extending hormone therapy by 5 years provided no benefit over 2 years of extension, and it was associated with a greater risk of bone fracture. However, if you look at the group of patients included in this ABCSG trial, 72% of the patients had tumor that were smaller than 2 centimeter, 66% were node negative, and only 20% of the patients were high grade tumors. So, probably this was a relatively low risk population. So, therefore, we cannot really rule out whether the high risk group would benefit with a longer duration of treatment. Another issue in this trial was that almost 20% of the patients after 2 years of randomization were not taking anastrozole, and by 5 years this percentage increased to almost 33%. So non-adherence to treatment was a substantial issue in this trial, which could actually confound the benefit of treatment. Now, another major issue when we are giving extended hormone therapy is actually the development of side effects, which include genitourinary side effects, arthralgias, myalgias, cognitive dysfunction, hot flushes, and so on. And another issue is the development of drug resistance, which leads to failure of treatment. So the third trial that looked at these issues is called as the SOUL trial, which looked at continuous versus intermittent extended adjuvant letrozole for breast cancer. And these are the final results of this SOUL study. This study also has been published by Guy Jerusalem and in Annals of Oncology this year. Now, the rationale behind this study was that in animal models, the resistance was reversed with restoration of the circulating estrogen level during interruption of the letrozole treatment. So that's why these authors they tried intermittent letrozole as compared to continuous letrozole. And in a sub study called as SOUL EST, they analyzed the levels of estrogen during interruption of the treatment. So in this study also, these study patients were primarily node positive patients, which were operable breast cancer, postmenopausal, and again these patients were enrolled between 2007 to 2012. And these patients had undergone already 4 to 6 years of adjuvant endocrine therapy, and they were randomized to either continuous letrozole, which is 2.5 milligram daily for 5 years, or the intermittent group received 9 months of treatment followed by 3 months gap, 9 months of treatment and 3 months of gap, like this for 4 years. And in the fifth year, they received again 2.5 milligram OD for complete 5 years. For the SOUL EST study, there was a 3:1 randomization where 78 patients were included in the intermittent group and 25 patients were included in the continuous letrozole group. Now, the results of this study have shown that this was actually they were trying to look at the superiority of the intermittent letrozole because of the animal models they showed benefit of the intermittent letrozole. However, there was no significant difference in terms of the disease-free survival in the intermittent group versus continuous group. The reported adverse events were also similar in both groups. Circulating estrogen recovery was demonstrated within 6 weeks of stopping the letrozole treatment. So again, this is I think a very important clinical point that after you stop letrozole in 6 weeks, the estrogen levels recover. There was no difference in the disease-free survival, overall survival, distant disease-free recurrence, and so on. So essentially, the two arms are absolutely identical. So the conclusions of the author are that extended adjuvant endocrine therapy by intermittent administration is not superior as compared to the continuous use. However, it suggests that intermittent extended treatment is a valid option for patients who require or prefer a treatment interruption. Now, my take on these trials is that the GM4 trial has shown us that extended treatment is definitely better than no extended treatment. So patients should be given extended duration of treatment of adjuvant AI. The ABCSG trial has shown that 2 years is as good as 5 years of treatment. However, as I mentioned, the number of group of patients was low risk group, so in which one can expect this. Whether the high risk group will benefit or not is something a matter of speculation. The SOUL trial has shown us that intermittent endocrine therapy is an option, but it is not better. I feel that it will be confusing for the Indian patients to stop treatment like this intermittently, and it may worsen the compliance issue, which may compromise the treatment. So one has to be really careful and discuss with this patient while using this approach. Now, if you look at the several trials that have already been done so far in using the extended AI, studies have looked at 5 versus 10 years, 5 versus 8 years, 6 versus 9 years, 7 years versus 10 years, and so on. Overall, it looks like probably 7 years is as good as 10 years. But in those group of patients who are high risk of developing recurrence, probably it would be better to go for 10 years of treatment. The extended endocrine therapy appears more, the effect are appearing more pronounced in women who switch from tamoxifen to an AI. We really do not know whether those patients who have upfront received the aromatase inhibitor right from day one, what would be the benefit of extending ET beyond 7 years? We don't know really. Similarly, in many of these trials, the benefit of the extended endocrine therapy was primarily by preventing the contralateral breast cancers and second primaries. So those women who have undergone bilateral mastectomy, how much benefit they would have with extended DT again is a matter of conjecture. Again, many of these trials have a short follow-up at this point of time. Probably, I feel that for all these trials, we should have a 15 or 20-year follow-up also to understand, because the EBC CTCG meta-analysis shown that even up to 20 years, the patients are at risk of developing recurrence. So we should actually have a more longer follow-up of all these trials. So as of now in clinical practice, how do we decide? So though there are look at the prognostic factors of recurrence, the clinical factors, that is the nodal status. Those patients who are node positive are at higher recurrence. Then those who have larger tumor size, their risk of recurrence is increased. Higher grade tumors are at a higher risk. And similarly, also look at the level of estrogen receptor expression. Those who have higher ER expression, their risk is less. But those who are low ER positive, say alternate score is say 4, 5, 6, like that, they're probably they are at a higher risk of recurrence. The breast cancer index score has been validated in some trial where they have shown that it is able to predict the risk of recurrence. So one can use this index. The other also can give you an idea about the risk of recurrence. So one should take into consideration and have a individualized decision making with patient, and accordingly choose whether the patient should receive extended endocrine therapy or not. So similar to the chemotherapy benefit or decision making that involves in going ahead with chemotherapy, I feel for endocrine therapy also one has to look at the TNM factors, that is the tumor size, disease stage, and nodal status, and also look at the biologic risk of disease. Those patients who are in this spectrum where their stage is higher and biological risk is also higher, they should definitely receive escalated endocrine treatment in the form of a increased duration of treatment, which can be up to 7 to 10 years of duration, depending upon the patient risk profile and also the tolerance of the patient. As the SOUL trial has shown us, in case if the patient is experiencing side effects, one can interrupt the therapy for a few months, and studies have shown that in addition to doing exercise and other treatment options like duloxetine and other medical measures, acupuncture, we can interrupt the treatment for some time, and many patients who interrupt the treatment for some time are then able to better tolerate the adjuvant AI in a better manner. So I think that is how we should approach in clinical practice. I would thank you all for your kind attention. Thank you.